It's really a pleasure to be involved in this Monday seminars. We have an excellent expert panel today to take us through the journey of kidney cancer and the issues related to kidney cancer with a particular focus on treatment. So kidney cancer incidence in Canada is about 9,000 a year, with about 20% expected death of that, and about 81,000 in US, and again, about 20% expected deaths from that. Male to female ratio is 2 to 1. Lifetime risk for kidney cancer in men is about 1 in 43, and in women, 1 in 73. Average age of diagnosis is about 65. The most common cases, I suppose, would occur in the fifth to seventh decades. It represents about 2% of all global cancer diagnoses and 2% of global cancer deaths as well. It's now currently the ninth most common cancer. So today we're going to particularly focus on renal cell carcinoma. So kidney cancer usually refers to renal cell carcinoma and carcinoma of the renal pelvis. Renal cell carcinoma is the more prevalent disease that all the talks today are going to be focused on. And this is a type of cancer that arises from the renal tubules. It's the most common type of adult kidney cancer. Histologically, as a pathologist, I tend to focus on the histology. So histologically, it's not one type. There are many subtypes. Currently, the WHO divides them into 22 subtypes. However, 75% of the cases are usually the one type, the clear cell renal cell carcinoma. Second most common is the papillary. Third most common is the chromophobe. So these comprise about 95% of the cases. And then the rest of the entities are within 5 to 10%. However, our understanding of these subtypes are changing. In the past, we didn't have good tools to diagnose the molecular subtypes. So many of what we now recognize as different entities were in the past probably lumped within the clear cell and the papillary and the chromo, the top three. Incidence might change as we understand more, and now we have the tools and molecular testing and immunohistochemistry to characterize these better. Risk factors, there is a genetic predisposition. There are familial mutations that predispose certain families to the risk of renal cell carcinoma. Chronic kidney disease is a risk factor, poorly controlled hypertension, occupational exposures, smoking, and obesity. The problem of renal cell carcinoma, it's a silent disease. Classic triad clinical symptoms is hematuria, flank pain, and a palpable mass. This is a really late stage in diagnosis. And most cases currently are incidentally discovered on imaging for something else that would discover renal cell carcinoma because they're often silent. And that's really the problem, because survival is highly dependent on the stage, a diagnosis. High stage disease, metastatic disease, stage 4 disease, of course, has poor prognosis, about currently 12% 5-year survival rate. Treatment has evolved. This is a very basic overview of treatment. Our experts today are going to speak more, but early stage disease are usually either when the cancer is still confined to the kidney, is either a surgery with removing part of the kidney, partial nephrectomy, or the whole kidney, or ablation. There are new techniques that are minimally invasive that would also burn or freeze the tumors and get rid of it. But later stage diseases, these require systemic therapies, chemotherapy, radiotherapy, the idea of targeted therapy and immunotherapy, and our experts today are going to walk us more through these. So this is my overview. Now I would like to go ahead and present our first speaker, who is Dr. Vincent Castillo. So Dr. Vincent Francis Castillo earned his medical degree and completed his residency training in anatomic and clinical pathology in the Philippines. Currently, he is pursuing his PhD studies in the Department of Laboratory Medicine and Pathobiology at the University of Toronto, under my supervision and Dr. Theodore Vanderpost's supervision. Dr. Castillo's research focuses on papillary renal cell carcinoma, a less common but clinically significant subtype of kidney cancer. His work investigates the role of ABCC2 as a prognostic biomarker and a potential therapeutic target, and he will tell us all about it now. Thank you.
When we talk about renal cell carcinoma, as Rola mentioned, we're really talking about like a diverse group of tumors. The most common type is the clear cell, as Rola mentioned, makes up about 70 to 80%, and the remainder, 20 to 30%, is commonly referred to as a clear cell renal cell carcinoma, or they are commonly grouped together as a non-clear cell renal cell carcinoma. But as a pathologist, we think of a non-clear cell as still a diverse group of renal entities. Each has its own histomorphology with different molecular and clinical profiles. And if you look at the current WHO, there are over 20 recognized RCC subtypes. But today I will focus my talk on papillary renal cell carcinoma, which is the most common non-clear cell renal cell carcinoma. So papillary renal cell carcinoma, or PRCC, is the second most common histologic type of adult kidney cancer, right after clear cell RCC. And like clear cell RCC, it is thought to come from proximal tubules. However, in contrast to clear cell, patients with PRCC tends to have a worse prognosis when it comes to advanced and metastatic setting. And this is primarily due to the lack of reliable prognostic markers. We have not enough studies exploring the biology and the immune microenvironment of PRCC, and limited PRCC-specific treatments. PRCC is often lumped or grouped with other non-clear cell renal cancers in clinical trials, which is not ideal since PRCC is a distinct renal cancer entity. And so PRCC, especially those that are low grade, frequently harbor the MET mutation or MET alteration and gains in chromosome 7 and 17, although we don't usually need to test for this molecular alteration to diagnose PRCC. We diagnose PRCC histomorphologically, and the current WHO classification defines PRCC as a renal tumor with papillary or tubulopapillary architecture without specific features of other renal cell carcinoma with papillary architecture. And so to diagnose PRCC, we commonly use a panel of immunostain in order to rule in PRCC, like for example, the CK immunostain and the AMACOR, and rule out mimickers of PRCC, for example, the FH stain as well as the TFE3, to rule out molecularly defined RCC, which also commonly present with papillary architecture. And then after we confirm the diagnosis of PRCC, we look for histologic features that could tell us whether this PRCC is either indolent or aggressive. But it is important to note too that PRCC is a very heterogeneous kidney cancer. And for the past few decades, pathologists address this heterogeneity by dividing the PRCC into type 1 and type 2 based solely on histomorphology. You could see the type 1 here was lined by a single layer of small cells with small nuclei and inconspicuous nucleoli. In contrast, the type 2 was characterized by this large cell with abundant pink cytoplasm and a larger nucleoli and prominent nucleoli. And it was commonly believed that type 1 behaved indolently, and then type 2 tend to be more aggressive. And oncologists relied on this classification system to guide treatment decisions. But over time, it proved to be unreliable because of several issues, including about half of the PRCCs usually demonstrate both the type 1 and the type 2 histology, leading to a significant inter-observer variability in calling it either type 1 or type 2, and also the lack of consistent evidence of its prognostic value. And because of this, the WHO no longer recommends using histologic subtyping for PRCC classification. Another prognostic marker that we use in PRCC is the WHO isopnuclear grading, but there are also conflicting data regarding its prognostic significance. Therefore, the limitation of the histologic subtyping and WHO isopnuclear grading highlights the need for a more reliable marker to improve the patient stratification for PRCC. And a promising biomarker in PRCC is the ABCC2 or the MRP2. It is a drug transporter found in the apical membrane of the kidney tubules, particularly the proximal kidney tubules. It is highly expressed in aggressive PRCC and may play a role in their resistance to chemotherapy. However, ABCC2 might do more than just pumping out drugs. Some studies suggest that ABC transporter, like ABCC2, could also contribute to tumor growth and progression, making them potential targets for therapy. So we wanted to test out if ABCC2 using immunostain, using IHC, as a valuable marker in PRCC that can be used by pathologists in predicting patients' outcomes. So we collected 254 FFP tissue samples, and ABCC2 immunostain was performed in all samples. And based on the immunostain pattern, we stratified the cohort into negative, cytoplasmic, and brush border pattern. And this is what the ABCC2 immunostain looks like in the normal kidney. It is normally expressed by the proximal renal tubules. As you can see, the brown stain on the apical surface of the proximal renal tubules, forming what we call the brush border pattern. So we use the proximal renal tubule as our internal positive control. As you can see here, the glomerulus as our internal negative control. And here's an example of a negative ABCC2 along with its corresponding H&E stain, showing no ABCC2 expression. Below, we have the cytoplasmic pattern, where the ABCC2 staining appears weak or strong granular staining within the cytoplasm of the tumor cells. And this is the brush border pattern. We define it by the distinct ABCC2 staining on the apical surface of the tumor cell, just like the proximal renal tubules. And to further classify this pattern, we group the cases into less than 50% brush border and more than or equal to 50% brush border when the staining was the dominant pattern. We first look at the expression of the ABCC2 at the gene level across these groups using RNA in situ hybridization. And as you could see, the PRCC with brush border on immunostain, both less than 50% and more than equal to 50%, have an increased transcripts as evidenced by this red punctate dots or cluster indicating higher ABCC2 mRNA levels in these tumors. And in contrast, here is the negative and the cytoplasmic containing none to very few ABCC2 transcript. So this confirms the significance of the brush border staining identified on immunostain, which is associated with ABCC2 mRNA overexpression. We then performed survival analysis, and it showed that ABCC2 immunostain significantly predicts survival outcome for PRCC. In particular, the brush border pattern, you see less than 50% and more than 50% had worse disease-free survival compared to the negative and the cytoplasmic group. And the significance was still seen when we dichotomized the cohort, wherein the brush border group had worse outcome. And after adjusting for other variables like age, tumor size, and stage, ABCC2 brush border patterns remain to be significant predictor. In contrast, the WHO ISUP grading failed to show any significant survival difference. We also look at this clinically important cohort, those tumors less than or equal to 4 centimeter, clinically referred to as small renal masses. This is clinically important to identify because they have a very low metastatic potential and may actually benefit from an active surveillance. And as you can see, the ABCC2 immunostain stratified these tumors into a prognostically significant group, whereas the WHO ISUP rating did not yield any significant result. And so to summarize, we demonstrated that ABCC2 immunostain is a reliable biomarker for predicting survival outcome in PRCC, offering prognostic value beyond the WHO ISUP rating. ABCC2 immunostain can also be useful for small PRCC tumors, especially helpful in deciding whether to proceed with active surveillance with this patient. And you can check out this study in the Histopathology Journal. So to address other challenges in PRCC, we further explored this subset of PRCC, those with high ABCC2 expression or those with brush border pattern, as we believe that these tumors are aggressive, they are likely to metastasize and may require a more tailored treatment approach. So I'll be sharing some of the unpublished data that I've recently generated. So here, through our pathway analysis, we found out that PRCC with ABCC2 brush border is characterized by significant enrichment of the nerve-to-R pathway. We further validated this finding with multiplex RNA in situ hybridization, showing an increase in the NFE2L2 as well as the NQ01, which are markers of the nerve-to-R pathway. Just a brief introduction about the nerve-to-R pathway. It's our defense against exogenous and endogenous stressors by increasing the transcription of the cytoprotective genes as well as several multi-drug transporters. And cancer cells exploits this signaling pathway. So in cancer, the nerve-to-R pathway becomes constantly and uncontrollably activated, helping tumor cells, including the PRCC, become more resistant to chemotherapy and thereby more aggressive. And we have demonstrated this in our in vitro experiment. We use ACHN cells as our model for PRCC with low ABCC2, so those with negative and cytoplasmic ABCC2 immunostain, and KAKI2 cells as PRCC with ABCC2 brush border. And we treated these cells with cabozantinib, which is an inhibitor of multi-kinase kinases, including the MET, and this is also the first-line drug for metastatic PRCC. And as you can see, the KAKI2 and the ACHN had a concentration-dependent anti-tumor responses to cabozantinib. However, the cabozantinib was more potent in ACHN compared to the KAKI2. Therefore, the current standard, the cabozantinib, might not be as effective in treating PRCC with ABCC2 brush border. We then combine cabozantinib with two ABCC2 blockers. We have the MK-571 as well as montelukast. Montelukast, it's a known anti-asthmatic drug, which interestingly also has ABCC2 blocking activity. And this ABCC2 blocker enhanced the effects of cabozantinib on KAKI2 cells in synergistic manner. However, in the ACH cells, those PRCC with low ABCC2 expression, the drug combination was only noted to be additive. So targeting ABCC2 could be a promising strategy for treating patients with high ABCC2 expression. And we also investigated whether the patient with PRCC with brush border exhibit a particular or a specific immune characteristics that make them more likely to respond to immune therapy, given the growing evidence supporting immunotherapy or the ICI-based therapy alone or in combination for the metastatic PRCC management. And our immune profiling shows that PRCC with ABCC2 brush border are associated with higher exhaustive T cells, characterized by cytotoxic T cells with elevated PD-L1 expression. We also demonstrated higher expression of other immune checkpoints in PRCC with ABCC2 brush border, as well as higher immune signature predictive of a positive response to immune checkpoint inhibitors. So these are evidences that we think that PRCC with high ABCC2 or PRCC with brush border pattern could potentially benefit from immunotherapy or the ICI-based therapy. So in conclusion, historically, PRCC was classified into two types. We have the type 1 and the type 2 based purely on morphology. However, it is clear now that PRCC is much more complex, representing a spectrum of histological, clinical, and molecular variation. We have at one end, we have the low-grade tumors. At the other end, we have this classic high-grade tumors with mixed or overlapping cases in between. And this complexity highlights why a one-size-fits-all approach is not suitable for managing PRCC. And to best select patients for treatment, there is a need to move towards a biomarker-driven personalized approach. And one key in identifying the aggressive ones in PRCC is through the use of the ABCC2 immunostain. Tumors with ABCC2 brush border might be resistant to MET inhibitor, making the standard targeted therapy like the cabozantinib less effective. However, these patients could benefit from combination therapy, like for involving, for example, an immune checkpoint inhibitor or potentially an ABCC2 blocker.
Let me introduce Dr. Figlin. So Robert A. Figlin, MD, FACP, is the Steven Spielberg Family Chair in Hematology Oncology, Professor of Medicine and Biomedical Sciences, and Deputy Director for the Cedars-Sinai Cancer and Deputy Director for the Samuel Ocean Comprehensive Cancer Institute.
Well, thank you, everyone. And thank you so much for inviting me to participate in this wonderful series. And before we start going through the slides, let me just summarize a little bit of the history of targeted therapy for kidney cancer. I think we all know that kidney cancer therapeutics have changed dramatically in the era of targeted therapy. Since our first publication with Bob Mozer and I in the New England Journal of Medicine, which defined sunitinib's role as a VEGF receptor 2 inhibitor in clear cell RCC, it has been the backbone and the standard of targeted therapy options for all of our patients. And while we have improved their outcomes when compared to prior non-targeted therapy directed therapies like interferon, it is clear that we still have much to accomplish for these patients. We're going to hear a little bit of a discussion following my presentation about the role of maybe thinking about combinations of TKIs with immunotherapy, which I'm happy to address during the Q&A period as well, but wanted to focus my attention today on what is the evolving role of targeted therapy in kidney cancer. And as you can see on the slide in front of you, we just published an article just a few weeks ago that looks at targeted therapy in kidney cancer and what I consider to be the next generation of opportunities for our patients, and why the use of HIF-2-directed therapy may offer our patients something that VEGF receptor 2-directed therapy could not. We know that sunitinib is a VEGF receptor 2 inhibitor. There are other multi-kinase inhibitors that target MET, such as cabozantinib, that target other things like other targeted agents. But the question then becomes, are we missing an opportunity for targeted therapy? So what I want to present to you today is a brief summary of what is the rationale for combining HIF-2 inhibition with other targeted therapies as the first-line treatment for patients with clear cell carcinoma, so-called LIGHTSPARK-3, which was an open-label phase 2 trial. Rola, next slide, please. So I don't think I really need to reinforce for this audience that the time from discovery to delivery can sometimes take decades. And I want to stop and start by acknowledging the work of Bill Kaelin at the Dana-Farber Cancer Institute, where he was awarded the Nobel Prize in Physiology and Medicine now 5 years ago, where he spent most of his career trying to understand the signaling pathways in clear cell renal cell carcinoma through VHL abnormalities, hypoxia-inducible factor alpha, and VEGF receptor pathway activation. You can see on the right-hand side that clear cell renal cell carcinoma is driven by inactivation of the VHL tumor suppressor gene, which drives HIF-2, which then drives VEGF receptor, sometimes driving c-MET. And most of our efforts of the past 2 decades have been on targeting VEGF. We know the kidney cancer tumors are incredibly vascular, and their vascularity accompanies their VEGF overproduction. It wasn't until we discovered and understood HIF-2 that we were then able to explore novel targeted therapies that are directed not only at VEGF, but also upstream at HIF-2 as described in the picture on this slide. So what is the background? Inactivation of the von Hippel-Lindau gene leads to the overexpression of HIF, which drive the expression of multiple oncogenes, including VEGF. Constitutively active HIF-2 alpha is a key oncogenic driver in clear cell kidney cancer, and as mentioned, VHL is inactivated in ccRCC. We've been involved in the development of belzutifan and its prior agents that were called Peloton drugs, and we showed that the initial results from LIGHTSPARK-003 showed promising anti-tumor activity in patients that were basically previously treatment naive as well as in patients that were previously treated with targeted therapy or immunotherapy. So in 138 patients in LIGHTSPARK-003, a first-line clear cell RCC trial, we treated those patients in 50 enrolled in cohort 1, treatment naive, 52 patients in previously treated patients, and I'm describing for you today the results of the 50 patients that did not have prior therapy in the presence of metastatic disease. You can see that this is pretty typical in looking at patient characteristics and demographics. It's a male-predominant disease, occurs in a variety of patients, both African Americans and Caucasians. Patients generally have good performance status, either 0 or 1. And when they're looking at IMDC consortium risk groups, about half the patients were the favorable risk, 40% intermediate, and only 4% poor. And as you'll see in comparison to Aly-Khan's presentation that will follow, most of these patients, 80%, presented with prior nephrectomy. What are the proportions of patients that benefited? We used the IMDC consortium group, characterizing it as favorable or median and poor. And you could see a very large number of patients benefit from this therapy. 79% with favorable risk, 59% with intermediate and poor risk. And you can see that some of those patients obtained complete responses, 11% and 5% respectively. But overall, in the previously untreated favorable risk group, 79% of patients benefited. Another 21% had stable disease. And what's remarkable is that when you target the HIF2 pathway, none of the patients in the favorable risk group had progressive disease at the time of our analysis. The same is true for the intermediate and poor risk. And clearly, over 95% of the patients had complete, partial, or stable disease, with only one patient developing progressive disease at the time of the analysis. Looking on the left-hand side, you can see tumor response. And when one looks at the spider response or the waterfall, you see dramatic benefits, including complete responses. And on the right-hand side, you see the durations of those responses now extending out to years, demonstrating that clear cell kidney cancer is a VHL mutated, HIF2 driven, VHL receptor sensitive disease, which has remarkable benefits from the combination of HIF2 and VEGF receptor antagonism. Looking at the patients in response, you can see the median duration of response was over 2 years. The progression-free survival, the median duration is over 30 months. And the overall survival for kidney cancer patients not reached, now extending out to 4 years. So what I'm trying to share with you is that while we're all very, very excited about the role of immunotherapy in kidney cancer, whether that is IO-IO or IO-TKI, we also recognize that only about 25 to 30% of patients who are receiving IO-IO or IO-TKI have a tail of the curve, with 65 to 70% of patients ultimately developing progressive disease, suggesting that we might want to rethink the role of targeted therapy in kidney cancer when compared to ICI therapy in the future. Toxicity. We all understand the toxicities associated with VEGF receptor TKIs, and the two major toxicities associated with the addition of belzutifan are anemia. Why? Because HIF2 is required for erythropoietin production, and HIF2 inhibition results in a decrease in erythropoietin, producing anemia, grades 1 to 2 in about 3/4 of patients, grade 3 in about 10%, sometimes requiring erythropoietin supplementation. There is a modest amount of fatigue. There is some unexplained changes in pulmonary function with some shortness of breath associated. But I think you can see from this slide that there is minimal grade 3 and grade 4 toxicities that are associated with the combination of HIF2 inhibition and VEGF receptor TKI. Importantly, the hypertension associated with many of our VEGF receptor TKIs was not significantly increased when the addition of HIF2 inhibition. So let me just summarize and suggest to you, and happy to enter conversations in our Q&A period, that we should not bypass the role of targeted therapy in kidney cancer, as with HIF2 inhibition alone and in combination, at least in the United States, we have clear and unequivocal evidence that there is benefit, and there are now phase 3 trials in progress or planned in the high-risk resected patient population, as well as compared to other TKIs alone or ICIs in combination with TKIs. So become familiar with belzutifan alone and in combination. It'll be an important component of your armamentarium when delivering care for your clear cell kidney cancer patients. Rola, Sola, thank you very much for allowing me to present. Take care.
Thank you very much, Dr. Figlin. I will keep the discussion at the end. I personally have a lot of questions around that. And yes, so we'll address later the targeted therapies versus immunotherapy IOs, and we have a lot of things to discuss. So now I will present our last speaker, Dr. Lalani. Let me pull up Dr. Aly-Khan Lalani, MD, FRCPC. Dr. Lalani is an associate professor at McMaster University and a medical oncologist at the Juravinski Cancer Center. He's the chair of the GU Cancers Disease Site Team at the JCC. His academic interests include clinical trial design and translational work for GU malignancies. He's a scientist with the Escarpment Cancer Research Institute and an associate member of the Cancer for Discovery in Cancer Research at McMaster University. He's also a co-host of the podcast The View on GU. Aly-Khan was awarded the Elizabeth Eisenhower Early Drug Development Young Investigator Award from the Canadian Cancer Trials Group in 2022, and the Rising Star Award from the Canadian Association of Medical Oncologists in 2023. He has been appointed to Canada's Drug Agency Pan-Canadian Oncology Drug Review Expert Review Committee since 2024. So, Dr. Lalani, the floor is yours. Thank you.
Yeah, thank you so much, Rola, for that introduction, and really an honor to present with everyone today. And the focus of my talk is around a little bit of an update of where we're at for immune therapy in kidney cancer. You've heard a great presentation on the evolution of targeted treatments, and then I'll dovetail into a little bit about how we're looking to combine treatments in kidney cancer to help our patients, particularly in terms of novel approaches with radiation. So there's been an evolution of immunotherapy. We'll look at the multimodality, and I would just highlight a trial that we've shown here in Canada and now running internationally with Australia of how to answer the question in patients who unfortunately present with a brand new stage 4 kidney cancer. These are patients who have not had a resected kidney cancer a while ago and then recurred unfortunately later with disease. They have presented stage 4, and as you heard from Dr. Figlin, this is a very unique clinical group, and we think biologically a little bit different than the typical patient. So there's options for radiation therapy we'll talk about, and we'll show how our own trial embedded important correlative studies that we can work with OICR and others on as well. So this is part of what Dr. Figlin has presented, and there's an evolution here, and this timeline continues to expand. So just to highlight that back in the 90s, there was treatments including interleukin or interferon. This was, I guess, what we would call historic immune therapy in some way. Responses were noted in some patients, but not the majority, and toxicities were high. With the understanding of von Hippel-Lindau as a tumor suppressor gene, this led to a whole bevy of VEGF, and specifically VEGF receptor-directed therapy, although bevacizumab targeted the growth factor. And this really led to, I think, advancements, as you've heard, and what we're trying to build upon in kidney cancer for over a decade. Then, like many solid tumors, immunotherapy became available for pre-treated patients and now has become a standard of care in the first-line setting, either combining with pure immune therapy as nivolumab and ipilimumab, or as IO, what we call IO and TKI, targeted therapy combinations, and we have many, and again, all approved and available in Canada. You've heard about this briefly, but again, I'll just make mention that the reason this continues to be important is we know that most patients have an acquired alteration in VHL, and with an alteration in VHL, this would let HIF alpha really move into the nucleus unabated and lead to transcriptional activation of HIF target genes like VEGF and PDGF. And it's these that go to the endothelial growth factor receptors and it's where the targeted therapy drugs have largely been active. But what you'll see here is for patients who obviously either inherited this or also acquire it now, there is an opportunity to have a direct anti-cancer effect at the tumor cell, not at the endothelial cell, through HIF-directed therapy, and that's what Dr. Figlin had showed you already. And I do agree we should all get comfortable with this because there's more to come and likely earlier on in the disease spectrum. And this, as you know, led to the Nobel Prize co-shared by 3 folks, and really a lot of this has moved the needle and helped us understand oxygen availability and how cells adapt, particularly in kidney cancer. Now, why does that matter? And what I'm bringing up, we did have, as Dr. Figlin also mentioned, IMDC risk groups. And very simply, in that era I showed you of targeted therapies, we learned that there's important patient factors, whether it's their performance status, the timeliness from their initial, let's say, surgery for localized disease to needing systemic treatment, or certain blood tests that can put folks into prognostic risk groups. And if they have no factors, they're generally thought to be favorable and have lived, just over 40 months. If they had 1 to 2 risk factors, they got about 2 years on targeted therapy. And if they had, unfortunately, 3 or more risk factors, they had less than 1 year. Keep this in mind, because we'll see how immunotherapy has leveraged this and try to do better. And again, probably this group knows well the interface between the cell and immune system. Very briefly, we do have our own immune response to foreign pathogens, parasites, viruses, cancer cell antigens. And obviously, we don't want these constantly active, so we have checkpoints in our body. But there are ways for us to have checkpoint inhibitors when in situations of cancer, you actually don't want to ramp down your immune system. If anything, you want it ramped up. So these are key places along that cell immune interface where we can put checkpoint inhibitors. For example, instead of calming down the priming and activation of T cells, when you put an inhibitor like ipilimumab, this can be revved up. We want immune cells to go down the bloodstream highway and really find cancer cells, and we can have a more immune permissive environment when we give targeted agents. And then obviously a lot of these that you see on TV, if you're in the US or certain commercials in Canada, you'll see PD-1 or PD-L1 inhibitors, and this really takes the cloak off the cancer cell and lets it be easily recognizable for T-cell directed kill. And so you can see that, well, we want kind of all of this to be a little bit more active, so why don't we combine some of these, and I'll show you how we've done that now. And this is really where we're at. This is not meant to cross-trial compare, so I want to be very clear about that disclosure. But in general, as of really this month, we've had updates in a variety of clinical trials, phase 3 trials, that tried to compare how combination treatment would fare against sunitinib. So ipilimumab and nivolumab, this is combination immune therapy. Pembro and axitinib, a PD-1 with a TKI. Nivolumab and cabozantinib, PD-1 with a TKI. And pembrolizumab and lenvatinib, a PD-1 with a TKI. Now, all these risk groups I showed you varied across the trials, and the primary endpoint was different across Nivo-Ipi for the intermediate poor risk. However, you are now seeing, and as Rola showed you earlier, historically what our expectations of 5-year survival was. Look at the median follow-up we have. We have 50 months and beyond, maybe over 5, even 8 years for these new immune therapy phase 3 trials that are all approved in Canada. And you can see, look at the median survivals. These hazard ratios tell you there's an improvement in patients' lifespan. And you can see the median survivals. Now, again, slightly different patient populations, but in general, we're getting median survivals in a 4-year range, which again had not been seen previously. On the far right, again, not the focus of this presentation, but putting nivolumab, ipilimumab, and a TKI like cabozantinib was a very good idea and remains one. However, you can see that survival was not improved. And in our discussion, we can talk a little bit about why 3 drugs didn't work as well as 2 drugs in one clinical trial. But clearly, I think the take-home here, my take-home message is that immunotherapy, either 2-drug immunotherapy or IO and TKI, is the standard of care for kidney cancer patients and has been for a number of years. These are all available for our patients in Canada and many countries around the world. Now, one challenge we had is how do we deal with the patients who may not be the best of the best. So what this means is that this Kaplan-Meier plot on the top left is really just to illustrate in those patients in this Nivo-Ipi or Checkmate 214 trial, For those who ended up having a response, so again, these positive patients, over 40% of the trial, between the two arms, you can see the duration of response is so long with immune therapy that it looks almost like it's got a tail of the curve. When you hear about tail of the curve, these might be some patients who still have not had their cancer grown in a first-line stage 4 setting, and that median duration of response is over 80 months, which is, really unheard of. Now, again, there's limited numbers here. These are only the best of the best, but, that's where that durable response in immune therapy-based treatment, you might hear a lot about that. This is the way it could also look on a curve of progression-free survival, meaning the time point between the patient starting on treatment and having disease grow or the patient die. There's a certain time point where if a patient has not progressed, meaning they have not had progression, that there might be a proportion of patients, maybe 1 in 4, that by many years out still have not progressed. That's what it looks like as a tail of the curve. And again, that's what immunotherapy offers in kidney cancer, melanoma, other cancers. These are the best of the best. The issue was the other side, and this is where our group had a lot of interest, is in these clinical trials with immune therapy. I'm just showing one as an example. For those who present with a target kidney lesion, meaning they presented stage 4, a kidney cancer mass already spread, didn't have the privilege of having it cut out in a curative intent years ago, so they presented with everything stage 4, there is a 0% chance of having a complete response. The kidney mass is huge. There's a large amount of burden. Systemic therapy, regardless, will not give a complete response. And that's either sunitinib or combination immune therapy. This is the group that when I wrapped up my fellowship in Dana-Farber in 2018, I thought, well, there must be an opportunity here. So what do we do to help these patients, maybe 30% of our patients who present brand new stage 4? Well, there was data, and Dr. Figlin knows this obviously very well, about doing cytoreductive nephrectomies, meaning in a stage 4 situation, still cutting out the nidus of the cancer, being the kidney, and still continuing on with some sort of systemic treatment. And there was perhaps in an interferon era that some patients who benefited from having a stage 4 cancer surgery, cutting out the kidney, perhaps the benefit was mostly in those ECOG 0 means excellent performance status patient, probably a surrogate that the majority of the kidney cancer burden was in the kidney and not too much spread or causing other symptoms or quality of life issues. Since then, there were trials in the era of targeted therapy saying, well, let's take all these stage 4 patients, randomize them to get that nephrectomy, even in stage 4 disease, and then start treatment or start treatment up front. Let's show that there's non-inferiority. And in the reality is, yes, there was non-inferiority. This is sunitinib alone. And in fact, there was a hint that maybe it's better not to delay patients getting treatment with waiting, booking, completing a surgery, recovering from surgery, and then getting treatment that goes all over the body, which we call systemic treatment. Maybe it's better to start up front with a systemic treatment. That was one hint. The CERTIME trial said, okay, well, why don't we look at, instead of surgery or not surgery, let's just look at doing it later, so systemic therapy up front, or immediately doing surgery. And you can see this Kaplan-Meier curve seems to show that deferring the surgery to get upfront systemic treatment might be the right thing to do. So around this time, we started to ask ourselves this question at our center and others: what about leveraging radiation? Now, again, to put on one slide 2 to 3 decades of historic teachings around radiation. Previously, radiation was thought that it's only helpful in kidney cancer if patients have pain or bleeding. Radiation doses were very conservative because it was felt that kidney cancer was a radioresistant tumor. Technology was limited. But then with new technology that we had in the 2000s, it allowed an ability for our radiation oncology colleagues to switch to smaller volumes. You could then escalate the amount of radiation dose delivered. So you have a smaller volume, you could pour more radiation into that area, and that allowed for hitting, for example, spread sites or metastatic sites, kidney cancer going to lung or liver or bone. But then this gave way to even higher doses, where instead of giving 1.5 to 2 gray per day, and this is kind of how you prescribe radiation, you could deliver 6 to 10 gray per day. So now we got better technology, ability to leverage higher doses. And this became, in some cases, called Stereotactic Body Radiation Therapy, or SBRT, I'll call it moving forward. So now radiation while systemic therapy on that timeline I was showing you was advancing, so too was radiation. And so now here comes our unmet need and how this really led to the birth of our trial. So I showed you those two surgical studies that said, hey, maybe cutting stage 4 cancer up front for all patients isn't the right thing. I still think there's a role, by the way. That maybe we should do something else to reduce the cancer burden in the body beyond giving IV or oral treatments. And SBRT is a short, convenient treatment completed in maybe 5 fractions and gives a high ablative dose. You can create what's called steep dose gradients to really avoid normal organs being hit. Obviously, you don't want to hit good tissue, and you want to focus on the kidney. And I'm just highlighting some kidney masses we've treated. The really interesting scientific part is that perhaps giving SBRT led to an upregulation of key immune modulating cytokines. That when you gave radiation and then cut out the kidney and looked at it under the microscope or with other sequencing techniques, that we saw things like calreticulin and CD8 proliferating T cells go up compared to if you just cut it out. So there's something the radiation is doing. And there's some data around this. We saw in some of the first data in kidney cancer back in 2017, 16 patients with a spread kidney cancer treated with SBRT. There's 15 gray to the primary tumor, so even more than 5 or 6 or 8 gray, followed by cutting it out, a cytoreductive nephrectomy 4 weeks later. So radiate and then cut it out and compare it to specimens of just getting into surgery alone. And you could see these things look visually different. We could see things like the CD8 positive T cells being different and other markers as well, which for the time I have, I won't go into, but there was a very clear scientific rationale to say not only can radiation help, maybe it will create more of these T cells. And perhaps if you also give immune therapy, could there be the holy grail in cancer, which is synergy? And so this is really our schema for a clinical trial that I'm proud to say we opened and have now recruited as of April 2024. We'll talk a little bit more in our Q&A about where we're at for this study. But essentially, it took all patients. We mandated a biopsy-proven advanced kidney cancer. Now, we allowed clear cell and non-clear cell patients that would have gotten typical standard treatments. These were by definition in the intermediate and poor risk group because that's how the control arm had approval in Canada. We said that they had to have a primary kidney mass. So that's the group that is de novo RCC. And we allowed kidney lesions as high as 20 centimeters, but anything beyond we thought was a little bit too large. So these patients got randomized to the control arm, which is the standard of care, covered, reimbursed in Canada, no delay, onwards with treatment. Or a 2/3 randomization to get first cycle of immune therapy, followed by radiation to that primary kidney mass, followed by the rest of the immune therapy. I think a very clean, straightforward design. The primary outcome was 1-year PFS, and you're going to tell me, whoa, we're almost there. If you finish recruiting in April 2024, we're coming up to that 1-year time point. And you're right, we are. We're quite excited for that. Obviously, this is a randomized phase 2 trial. It's non-definitive, meaning there are phase 3 plans and already some trials ongoing. But we're going to be the first to read out, and we want to show safety, survival, response. We've got some really exciting correlatives I'll talk to you about. All patients had a baseline biopsy. We captured that tissue. We took blood at baseline and at cycle 2 for each of these arms because one of the arms had radiation. And we actually looked at the gut microbiome. I was very fortunate to establish microbiome platform at our cancer program. And we asked that as well. And at McMaster, Sunnybrook, Ottawa, our colleagues in Grand River, Alberta, McGill, and Peter MacCallum in Australia all participated. And we're pleased to say, again, we've recruited and are looking to present that data shortly. So we're off, right? February 2020. I'm fairly keen. I'm now 2 years into faculty, and we get to launch my first kind of IIT. World Cancer Day comes February 4th, 2020. Think back. And we're really excited. And we recruit our first patient. And then something happens after those few weeks in 2020. COVID, literally we opened our trial, recruited, and then COVID happened a month later. I know we're all kind of so-called sick of hearing about that, but it did lead to a pause. We were able to reopen our trial and still conduct it. Along the way, we had many grateful patients who wanted to share their story even before the trial had read out. These were patients who, I'll never forget, came to my clinic with a large kidney mass, having had it spread, bleeding from the kidney, had a catheter in, sent from a urologist, willing to try anything. And I had patients driving all the way from Niagara on the border of Buffalo, coming to see us, and really had a good benefit and wanted to share their story. So we're very grateful for their participation in trial, and they're willing to tell their story as things went along. I did mention that we did have the clinical support for this through our BMS industry partner, but we also, I applied with my colleagues, Jonathan Bramson from the HITS lab and Mike Surrett from the Surrett lab, which leads our microbiome work, on a BioCanRx. This is a federally reviewed grant, and we were awarded a total project purse of 1.3 million, where again, we're going to contextualize the genomic and immune profiles of baseline tissue and liquid biopsy samples, which are on therapy and at progression. And we also seek to do comprehensive microbiome analysis and recapitulation of bacteria functionality, because we don't even really know in kidney cancer what a so-called good baseline microbiome is, adjusting for diets, where patients are born, where they live, and what their life is like. But changes with radiation and with radiation or immune therapy we thought would be of interest, so we embedded those correlatives into the trial. So we have some deliverables for BioCanRx. We've completed the trial recruitment. That was deliverable 1. We have blood and tumor tissue immune profiling, a lot of exciting work, and certainly can work with provincial and national and international partners on this, and then the gut microbiome as well. So we are looking forward to firstly the clinical readout, but there will be a immune therapy and correlative readout as well. Why is this all important? Well, I think you guys know this well. Kidney cancer is in the middle of the mutinome pathway. It's not at the end of bladder and lung and melanoma, so it's not going to be enough to talk about tumor mutational burden. This doesn't work to explain kidney cancer. We can see where lung cancer and melanoma is, but when you look at where it sits on the far right, would be in cytolytic activity. So even despite its low mutational burden, the tumor cytolytic activity and T-cell infiltration signatures, so the qualitative burdens will probably be more helpful, and there's lots of exciting things like KIM-1 and other recent protein-based analysis that are being hot in kidney cancer that we're looking to analyze as well, given we have all these samples. Just a quick shout out, this couldn't be done without our CytoShrink correlative team. So the HITS, or Human Immune Testing Suite, is a BioCanRx core facility. It's located at McMaster. It supports immune monitoring for preclinical phase 1 to 3 and multi-site clinical trials. And we coordinate, and we have things like serum, we have things like plasma, and looking to work with OICR on that. We have work with PBMCs. And just to say, we aren't the only ones that are going to answer this. We have the Nordic Sun Group looking at Nivo-IPI and then seeing if they should be getting cytoreductive nephrectomy or not. So still looking at cytoreduction in an immunotherapy era. The PROBE trial in the US doing the same. We have my colleagues with Tony Schwery and Raina McKay looking at the Samurai trial, again, using lots of different systemic treatments as well through NRG oncology. So I'll just wrap there by saying, look, this takes a village, especially at the time I was, I guess I still consider myself a young investigator, but it took a lot of faith from mentors to help you along the way. Firstly, their patients and families for participating, a whole trial team, my co-PIs, the trial department, coordinators, investigators across the world, our academic sponsor, our industry sponsor, and again, mentors and advisors along the way. So I just wanted to pause there. If you're interested in hearing more about GU cancers clinically, we have a podcast and YouTube channel. And I did really want to thank you for the time of being invited and participating with you today.